Welcome to everybody to the last episode of the Daily Reporter live commentary. I'm Antonio Passaro. I'm a medical oncologist from the European Institute of Oncology in Milan. It's a great pleasure today to share this very interesting discussion of a new immunotherapy agent, immunotherapeutics, with two great colleagues. So we have Alessandra Curioni, that is the head of thoracic oncology and the translational lab at the University of Zurich. Welcome, Alessandra.
Hi.
And we have a Sebastian Kobold, that is a professor of medicine and experimental immuno-oncology in the University of Munich in Germany. Welcome to everybody.
Hi.
So in this ESMO meeting is, of course, the corner of the satisfaction for all the clinician about the immune checkpoint inhibitors for solid tumors. But we know that we are looking forward. We need in clinical practice to understand how to improve the survival, the efficacy of these agents in our patients, particularly with solid tumors. And there was a very interesting presentation of discussing new immunotherapeutics agents, also the new strategy to improve the efficacy in this particular way. And I have very few questions, but a very focused question for all of us. So I want to start with Alessandra. So, Alessandra, what's your take-home message from the last development with the cellular therapy for solid tumor, and also with your expertise, in particular with melanoma?
So I have to say that the most important thing to say, the most important message, is getting more and more complicated, and it's getting more and more crowded. So we have the different attempts with different ways of doing CAR T cells. We have seen great results in GI tumors. And especially on mesothelioma, we have seen amazing results with this new technology by adapting the T cell receptor to recognize specifically a target that is mesothelium. This has been, I would say, one of the highlights for us that we work on mesothelioma, because in meso, as it is a rare cancer, not a lot is going on, with the exception of the latest data we have seen in immunotherapy with Nivo-IPI, with a checkmate 743. But a lot has been done in the past years, and I think these new attempts with cellular therapies might represent really a way to go, especially because mesothelioma is easy to access, and by this way we would overcome the possibility of cells that are not reaching the tumor due to tumor suppression and tumor suppressed in microenvironment. So I really am very positive.
Yeah, thank you. So the next session was, where's the main hurdle with the cell alternate at present time?
Yeah, well, certainly one of the main hurdles is the production of these cellular therapies. And at the same time, we have the main hurdle to make it in a way that they can reach the solid tumors. So that's why I think that's a positive thing of mesothelioma, what I was mentioning, because you can reach directly the tumor itself. I have to say that we will see that in the future. Another issue might be for sure the fact of having the heterogeneity of the tumor itself. So sometimes we will see that we have seen that only probably one target is not going to be enough, and multiple targeting might be a way to go.
Okay, thank you. Thank you very much, Alessandra. So, Sebastian, considering your great expertise in the field, I have a question for you that what are the advantages with the no tumor target antibody in solid tumors? So the way of the diagnostic approach or the way of the target approach? What are your thoughts about?
Yeah, so actually, in a sense, we're all very used to already to a non-tumor targeted immunotherapeutic approach, because we all know and are using in the daily practice checkpoint inhibitors in various indications, of course. And this was really the first, the first immunotherapeutic wave, if you want, not targeting the tumor, but still reaching benefits for the patients. But so obviously the field has been centered very much around T cells and around these axes for many years now. And what is going on now, and it was, I think, very clear now in some of the immunotherapeutic sessions that we saw earlier at ESMO, was that there are more and more efforts going on to harness different other mechanisms or modes within the tumor microenvironment or within the immune system that are of relevance to suppress the immune response. And so just to give you one or two examples, I think we've seen a very interesting clinical study now where they targeted not the T cells themselves, but myeloid cells in an effort to convert them from an immunosuppressive state into an immunostimulatory state, with the idea that then you would reinvigorate the immune response, not so much directly T-cell related, but in this case myeloid related, eventually secondarily to drive a T-cell response. And I think there were very encouraging results, beneficial safety profile, which clearly calls for more. But as always, these are very early trials with very advanced patients. And I think we've seen a number of these very attractive approaches. Just want to highlight one other, which I found very interesting, which is a dual targeting approach now. So targeting an axis we know very well, which is the PD-L1 approach axis, but on the other hand, neutralizing TGF-beta. So it's a fusion protein that targets both. And they've shown, actually disclosed quite dramatic responses in patients with HPV, so human papillomavirus positive cancers, very advanced cancers again, and even reaching, for some patients, complete remissions with just this agent, which I think for an early phase 1/2 trial was very encouraging. But of course, as always, we'll have to see what the future will bring. But I think, we need more of these approaches, and also to understand, pretty much as we need still to understand for checkpoint blockade, which are the patients that will benefit most, and so which are the patients we should be centering our attention to when giving those drugs. But this is still not clear.
Thank you. Thank you very much, Sebastian. This is very fascinating for all of us, and is also for our patient for the treatment of future treatment strategy. So I have a burning question for Alessandra that is a very simple question for all of us that are very clinic-based. And are we ready for the CAR T-cell therapy for our clinics for solid tumors? And what's your perspective now in the 30 seconds?
I think we are not ready yet. We are ready to participate to clinical trial, yes, but in just a few places. We need to make it much more easy to do and much more affordable also from an economic point of view, and this then it's going to make the field to have a big impact and a big change.
Thank you. Sebastian, your thought here?
Yeah, so I think we still have a long way to go. I mean, some of the challenges have already been raised by yourself and also by Alessandra earlier. I still think, that the cellular therapy field is much more than just much more than just CAR Ts. And I think some very interesting approaches outside of the CAR T field too are also just dawning. I mean, some of you might have already heard about tumor-infiltrating lymphocytes already many years ago, but it seems that they're still coming back of age in melanoma after the failure of checkpoint blockade, and some very fascinating results have been disclosed earlier this year, so which are quite encouraging also there in this field. So I think we have much more to come, but also much more to learn.
Thank you. Thank you very much, Sebastian. So from my view, thank you very much for this great discussion. It was my great pleasure to be here today and to conclude this new format by the ESMO for the expert commented by Daily Reporter. And I leave the word to Alessandra, that is the editor-in-chief of the Daily Reporter, for the last message or simple greeting to all of you.
Thank you really very much, Antonio, as the head of the press. But I want to thank the people who are behind all this this entire organization. Vanessa Pavinato, Sara Fontanella, Cinzia Pozzi, Valentina Bianchi. Thank you all very much. You have made an amazing work. And Thomas in Paris at Hospital Palazzo. Thank you guys, everyone. And thank you, Antonio, for supporting also this project.
Thank you. Thank you, everybody. Bye-bye.
Bye,
Thank
everyone.
you guys. Bye.